of the hour. Dr. Mithal, it is a pleasure to have you with us today. It is indeed a privilege. For everybody, Dr. Mithal is the Chairman and Head of Endocrinology and Diabetes at Max Healthcare. He is a leading light in diabetes and endocrinology, thyroid. So it is really a pleasure and a privilege to have you with us. Thank you so much. So as we start today, Dr. Mithal, we are sitting in the midst of a pandemic, and COVID seems to have hit everybody hard, but certainly India, because India is also the capital of diabetes. Even pre-COVID, we are like the #2 in the world. So, you know, as a general concern, we know that diabetes is a comorbidity. What can go wrong for people with diabetes? What do they need to look out for? And what are some of the precautions they can take?
So when the first round of COVID sort of hit the world, the very first studies that actually came out from China, they suggested that people with diabetes are at greater risk of poorer outcomes. Right?
Right.
So, and then subsequently from across the world and in our own data, which we published earlier this year, based on last year's experience, we find that people with diabetes are the ones who have poorer outcomes. What does that mean? If you talk of people with diabetes, are they at greater risk of contracting the infection? That data is very nebulous. We are not still certain that if people with diabetes are likely to just catch the bug. No.
Okay.
But if they do catch the bug, especially if they catch the bug to an extent that they require to be hospitalized, then the outcomes are definitely poorer in those who have pre-existing diabetes. And I'll explain that a little bit. So
yes,
what we found, for example, is that in our series of 400 consecutive patients with COVID,
right.
So, you know, firstly, diabetes is so common. 50% had some form of diabetes or the other. Half of them had some form of diabetes or the other. And the people with diabetes clearly had longer hospital stays, ICU shifts, and even succumbed to it more commonly than those without diabetes. Now, but there are qualifications here. It's not so simple. Don't be petrified if you have diabetes and you get COVID. Most people with diabetes and COVID do very well. If you're a well-controlled diabetic and your diabetes is not like 30 years old with multiple other organs involved, then you're likely to do as well as a non-diabetic.
Okay.
But if you have diabetes with high blood pressure, with kidney disease, with heart problems creeping in, if you have that kind of constellation of comorbidities, along with poorly controlled diabetes as a baseline. So we've also found those who were poorly controlled, when they were admitted, they had poorer outcomes. Those who were well controlled, A1Cs, A1C is a 3-month average, was 6 to 7, they didn't have bad outcomes. So control of diabetes, duration of diabetes, existence of other conditions, that has an impact on outcomes. So most of our patients have done very well. They've not had a problem. They've managed their diabetes well beforehand, and during their treatment for COVID, their diabetes was also managed well. So this is the impact of COVID, of how diabetes impacts COVID, right?
Yeah,
but
as a comorbidity.
Also look at COVID, how COVID impacts diabetes, and if you want, we can discuss that.
Yes,
how does COVID impact diabetes? Yeah.
Exactly where we're heading, Doc. So with steroids being the primary line of treatment, so let's talk about that, the impact there.
So there are 3 ways in which COVID impacts diabetes. First is any stress, any infection, any fever will raise your blood sugar. Anything, even a routine viral will raise your blood sugar.
Right.
First. Second is the fact that seems to be, still not finally proven, there seems to be a direct impact of the coronavirus on our pancreatic system and insulin system and all that. So there may be a direct specific virus specific impact also, which is still being studied.
Okay.
And the third is, of course, that this use of steroids in such high doses, which are actually life-saving if used at the correct time for COVID, they send the sugars through the roof. In 1 year of managing these patients, the proportion of 400 milligram and 500 milligram calls that I get, or even 600 or 700, I have never seen that number in my whole career. So the numbers are so high because you get an odd call at 600, the sugar 600. Not like everyone's calling you with 400, 500, 600.
Yeah, that's crazy.
So that's so obviously that has a big impact on outcomes. And so while on the one hand, steroids save our lives and they are very important if used at the right point, but clearly if they are not used correctly, or if the diabetes is neglected when you're on steroids, then you can get into trouble.
So, Doc, what are the short-term versus the long-term implications of steroid use here in this kind of thing? And especially with like the whole protocol being that you have to take it and then you have tapering off. So how does that work?
So again, before I go into the complexity of it, I will just say that steroids are very important. If your doctor advises steroids, please go for it. Typically, they should be used in the second week of illness, around day 6, 5, 6, not before day 5. The first half of COVID classically is what is the virus period, where the virus is replicating in your body. That time, steroids are not antiviral drugs. After that, the virus sort of fades off, but it triggers a very intense reaction, which is called an inflammatory response or a cytokine storm.
Yes.
Now, at that point, if you use anything for the virus, it won't make a difference. The virus itself is already fading away. It's the after effects that are damaging us. And at that point, steroids are the only remedy that's really been shown to work. So number one is that they are very important in treatment of COVID at the right time, not at the diagnosis, not test positive. Today the test is positive and you start saying, no, not at all. Number one. Number two, you have to use them sometimes, and that is the physician's judgment, in fairly high doses. And what happens with that is the immediate impact is a rise in blood glucose we talked about, which can impact everything, including increasing the risk of fungal infections and other things. Secondary infections, it can, the patient will not feel good. The outcomes may not be so good if sugars are left uncontrolled or untreated. But that's just one part. They also have an impact on blood pressure. Right. And the other thing is that they if used for long enough, which some patients they have to use for months, they have an impact on our many organ systems, but especially on our bones and muscles. So if someone has to, right now we are thinking of surviving, okay, so it's okay. But next year when we'll have used steroids for 6 months, 8 months, we don't know how long some patients are using it, then the impact on bone and muscle will start manifesting itself. The bones become weaker, the muscles become weaker. And osteoporosis, one of the major impacts of steroid therapy is long-term osteoporosis. However, using it for short-term therapy does not really have that impact. But if you have to use for months together, and some patients do, if they develop pulmonary problems, then it's a challenge. So steroids have multiple impact on the body. And the last and most important is, till you're on high-dose steroids, you're actually immunocompromised to some extent.
Yes, absolutely.
So that's another challenge, So also, last point is that when you really taper them off, why do you taper them off? Because they suppress the normal steroid production in the body. So the cortisol is not being formed anymore. So if you stop it suddenly, the gland doesn't get time to kick in. So you have to taper them off and reactivate the gland slowly, and then you're okay.
Yeah. Thank you, Doc. And I'm glad that you spoke about the long-term as well implications here, because that's something that is a cause of concern for everybody. And, right now it's unavoidable in a way. Doc, this whole thing about black fungus, and they're saying that, it is a higher risk for diabetics. First of all, can you actually share what is happening in black fungus? And is it related to the oxygen pipes like in hospitals? 3, how does it relate? Why are diabetics at greater risk? Can you just shed some light on this whole?
Yeah, so mucormycosis, as it's technically called, or black fungus, is a kind of dreaded complication, which we see in people with diabetes, forget COVID, which we do see in people with diabetes. Now, the important part is that mucor is a normal fungus. It's almost ubiquitous. It can be present in your and my nasal cavity even now, even today. So it's
Okay.
not that the fungus is suddenly spread everywhere or COVID has done something to the fungus.
Yeah.
The fungus is there. It waits for an opportunity. In a normally healthy person, it can't do anything. The body takes care of it.
Okay.
Now, however, if your immunity is severely compromised, which happens when you have very high blood glucose, when you're on immunosuppressive drugs like steroids,
Yeah.
when when you're overall compromised, or when you have a thing called acidosis, which happens in very sick patients, all those factors lead to the proliferation of this fungus, the overgrowth of this fungus. Same thing that is lying there quietly suddenly starts eating up your bone and muscle, and it has a problem of invading the vessels, the blood supply.
Okay.
And it uses iron, and that's why it becomes black. So it's called black fungus. So it can destroy your nasal bridge. It can do all kinds of ghastly things. Eyes
So the
and
entire
everything.
sino-nasal
Yeah,
passage, basically.
the whole thing can get
Yeah.
destroyed. So I mean, we see these infections. We see them typically in type 1 diabetics who have ketoacidosis, the children with diabetes. And it's not just the nose and throat. It can be in the lungs, intestines, skin. We've reported all those. But in the context of COVID, suddenly the prevalence has increased. So in absolute numbers, you won't be seeing a large number of people like that. It'll still be,
Okay.
it's quite rare. I mean, I would normally, in my normal diabetes endocrinology practice, see a couple of cases a year.
Right.
Maybe even some years may go, I've not seen a single case.
Okay.
But suddenly there are an increasing number of patients who suffer with this because they're going through this extreme immunocompromised state with severe severe hyperglycemia, we call it, very high blood sugars,
Yeah.
and all together. Plus the fact that some of them are on all kinds of pipes and other things, which could also be maybe contaminated, so that will add to the problem. But the basic problem is not that. The basic problem is within the body. Our resistance becoming so low.
Okay, so the resistance, and then that's all, I mean, it's all fed together with increased sugars, immune suppressant, I mean,
Correct.
steroids, and the whole
Yeah.
pattern is just like, so, but is there anything we can do to prevent it?
So there are some basics that we can do, and really shouldn't be happening. To be honest, it shouldn't be happening. I think it's
Right.
all preventable. Treatment is much harder than prevention in this case. Prevention means that you obviously oral and nasal hygiene is important. Proper rinsing of mouth, like even when people use oral these nebulizers and sprays,
Yeah.
it's very, very important to rinse and gargle after that. Don't
Okay.
leave that steroid floating around there.
Okay.
So proper oral hygiene, that's very, very important. Nasal hygiene also, not that you have to pour too much stuff in, but you have to make sure that you're cleaning. Okay.
All these people who are doing jal neti and all, should they be doing that or not?
I won't comment on that. Okay. So that is one. The second
Yeah.
is that this is, of course, I'm talking in general of those who have COVID. Yeah.
Yes.
The
Yes.
other thing is, obviously, judicious use of steroids. At least wait for your doctor to prescribe. Don't use immunosuppressive drugs like steroids randomly. And for doctors also to be very careful in prescribing. The doctors are also anxious. They've lost patients to COVID. They don't want to do, they just want to make sure the steroid they diya, that kind of thing.
Yeah.
So everyone has to calm down a little bit there. And thirdly, an area which I am seeing a lot, especially in non-specialized centers, because doctors are just completely flooded with trying to manage the oxygen and COVID and this and that
Yes.
not everyone has specialists available. So the attention to glucose control is sadly lacking in many of our patients. And our patients, I mean, across India. And
Yeah.
where people are struggling for oxygen, the last thing they're going to do is monitor the sugar all the time and make sure someone is adjusting, because it does require temporary insulin treatment.
Yeah. Yeah. Absolutely.
So there is I mean, those are reasons why it's really increased. And if we keep a check on those things, then we can significantly reduce our
So, Doc, you just mentioned that we need to monitor this closely. So, if somebody is at home and sort of managing COVID at home, not hospitalized, so how often? What would be the frequency that you would monitor and touch base with the doctor? What would be about right?
Yeah, it actually depends on the kind of COVID or the severity of COVID. A lot of people just sail through COVID without knowing anything. and nothing happens at all. But if you're again asking me in context of diabetes, yes, in the
Yes.
context of diabetes, number one, you should be in touch with your endocrinologist or diabetologist or whoever's treating you for that,
Yeah.
along with the your internist who's treating your COVID. It's
Sure.
important.
Sure.
On day one, don't wait for it to explode, which is what is happening to me. And with 400, 500, then you sort of suddenly say,
So as calls.
so that is number one. So if you're
Okay.
in touch with them and if you're managing at home, and this year has been different from last year for us. Last year, most such patients, we would say, just come to the hospital. There was only a week or 10 days when we couldn't get any beds. This year, it's been very long. And this year, we are managing these kind of sugars at home. So it has to be then, the problem is that you almost always, if it really is a flare up because of steroid, you have to use insulin at home.
Yeah,
So
absolutely.
for those who are not used to it at all, it's quite a challenge. But if somebody is using insulin, we can adjust the dose and make an algorithm for them and help them out. We are hand holding them quite a bit. I mean, numerous patients right now are under regular sort of contact with us.
So, Doc,
But
are there?
yeah,
sorry,
but also, I mean, it's important if you have not used insulin and then you have to initiate, that's a real challenge. Because then what we are doing is we have trained educators who teach you on video. And
Yes.
sometimes it's a 80-year-old who's got this problem and the kids are in the other room. It's all, it's pretty complex. But I would say the bottom line here is, along with your oxygen that you monitor, temperature that you monitor your blood glucose 3 times a day for sure.
Okay.
And that
So keep your
itself
readings.
and that itself will set alarm bells ringing and make sure that you're in touch with your doctor if the sugars are really going haywire.
Okay. Doc, is there any special care or concern for vaccine or treatment if one has thyroid autoimmune disorder?
Yeah, that's a question that's often asked. I don't know why that's floating around. The answer is no. The answer is there is no concern.
Okay, wonderful. And is there anything, is the vaccine somehow connected to diabetics as well?
That's another question that's floating around, that my sugar went up after the vaccination. No.
Yes.
People with diabetes, people with thyroid disorders must get vaccinated. Those who are on, who have more sort of, I would say, aggressive or serious autoimmune conditions where they are on immunosuppressive drugs, they should also get the vaccine. They may be advised to stop their methotrexate for 1 week or 2 weeks or something. If possible, they should talk to their doctor. But the reason for stopping is not because you're worried about any adverse impact of the vaccine. It's because the effect will be a little less if you're using immunosuppressive.
Got it. Got it.
Right? So you can still get it. You might get a little less impact than others. That's all.
Yeah. Okay. Thank you. Doc, for a diabetic who gets COVID, besides the HB1AC, what other tests do you recommend? Like KFT or LFT?
Yes, of course. When you do the first line of COVID testing, when you often do inflammatory markers and all, it's very important to keep track of the KFT and LFT for us, because KFT determines what drugs we can use. LFT determines, I mean, they rule out some usage of some drugs totally.
Okay, yeah.
So it's very important to know the condition. And also, they change the sensitivity to insulin. So you have to be aware of, you can't treat diabetes properly unless you have these two parameters done recently.
Okay, would there be any other tests that you would, tell our audience that they must have if they're diabetic with COVID, just so that they can, keep them?
Well, the usual COVID tests, the inflammatory markers, the CBC, ESR, but the one test that I'm finding is still missing in many patients, and I'm surprised as to why and how, because we talk about it like day and night, is the HbA1c, which is a 3-month average of sugar. Now, if you suddenly come to me with my sugar of 400,
yeah,
and if your HbA1c is 6 or 7, my approach is very different than if you come to me with a sugar of 300, 400 and an HbA1c of 10.
Right, absolutely.
So for those who don't know, HbA1c is an average of the last 3 months blood glucose. It's one single value that gives that average. And we would like A1Cs to be around 7 in most patients.
Yeah, and the ideal would be, I guess, between 6 and 7.
Correct.
Thank you so much, Doc. Now we're going to open to the audience, audience questions. So, Doc, the first one is from Rinky. Please recommend supplements to build immunity.
Yes. So To be very honest, I'm not a great believer in supplements, and
Okay.
immunity is not built overnight. However, what I would say is you take one multivite that should have most of the stuff, like one multivitamin, tablet, and you take some vitamin D on the side. So don't push high doses of vitamin D. All you need is about 2000 IU per day to build your
Okay.
immunity, to protect your bones, to protect your muscle, all those things.
Right.
So too much supplementation is happening. You can use a multivitamin that has zinc also. Okay, that's all right, acceptable. Nothing more than that is required. Healthy, nutritious diet, regular deep breathing and walking. Those are the more important things that are required. We did a study, just I'll loop you into this, on vitamin D. That's my other area of interest. We published that in Nature Scientific Reports in
Okay,
March.
great.
So where we looked at vitamin D status and outcomes.
Yeah.
So we measured the vitamin D level for 400 patients who were getting admitted, and then saw did it make a difference to their course in the hospital, and it did not make any difference.
Oh,
So vitamin D is for building long-term immunity.
yeah.
So you should not be deficient. But to expect that if you have COVID and you took vitamin D and it suddenly everything became okay, it's not as dramatic as that.
Okay. It's not a miracle drug. No supplement is going to give that
But
for you.
you'll find people who believe that, but
Yeah.
without data.
Okay. From Vidhi, my mother is 74 years old, recovered from COVID. She is a diabetic. She has high BP. Though her COVID period passed with little ups and downs, she's having low BP and sugar levels subsequently. So she's on insulin and she has reduced it. So is there any?
So I suppose she took steroids, I guess.
Probably.
So anyway, so this happens after COVID. Some people get low blood sugars after, some get high, some get low. And
Right.
they get low because of two reasons. Number one, that during COVID, they've been given steroids and the sugars went up a lot. And then the insulin was not readjusted or something when COVID went away, it wasn't readjusted enough. Or they were temporarily not producing enough cortisol within the body because the gland was resting. You know what I
Okay.
told you, inactivation of the glands.
Yeah.
And
Correct.
therefore the requirement will go down during that period. That's
Okay.
no. And other is that some patients of mine who had mildish COVID also improved a lot after COVID because they became very careful about what they eat. Because it's sort of, they were unwell and they were at home and everything was regulated. So just simple change in dietary habits improved their blood glucose after COVID.
And that's great. If that could be your side
Yes,
effect,
yes.
of staying home and managing your illness at home, that's fabulous. So, Rinki, thyroid is an ailment one has to live with. Please advise what thyroid patients can do to avoid or during or post-COVID.
So I think thyroid patients should be treated like anybody else
Right.
in the context of COVID. They don't have high risk. They don't have high risk for complications. They don't
Okay.
have, so you should not worry. Keep your thyroid under check, as is not so difficult. Be in touch with your doctor, check your TSH, T4, whatever. If those are normal, your risks for either contracting the infection or any complications are same as someone who doesn't have thyroid.
Okay, great. From Nandini, why does a person get hypoglycemic and what precautions does one need to take? And is there a level that you can
Yes, so hypoglycemia means low blood sugar reaction. And typically, we say somebody is hypoglycemic when their blood sugar falls below 70. But
Okay.
it may be, that is the classic textbook description, but it varies a lot because in an 85-year-old, and I'm treating several of those these days, 85, 90-year-olds, we don't want to even venture near that level. I'd be happier to keep them 100 or above. So you will have to ask your doctor, but the definition is 70. So there's no panic above 70. Okay. So, but for a particular patient, you may want to fix a different target depending on the overall situation. So hypoglycemia happens for various reasons, and one of them could be simply because you miss a meal. Very common. People miss a meal or don't eat enough or forget, or meal is very delayed. Then you can get hypoglycemia. Or they take a higher dose than usual for some reason, or they increase their physical activity suddenly. Every day between breakfast and lunch, they're just resting. But one particular day, they went out, for a walk with their friends. I'm talking of non-COVID situations. So all those things that can really cause a drop. Sometimes, despite all efforts, you can get a drop, and that is a biological thing, but that's not common. 90% cases of hypoglycemia can be traced back to one of these two or three things: change in dose, change in meal, or change in exercise.
Okay.
Right?
Great.
So if one is, but some people become very prone to it. They're very fragile, and that has to be handled with the doctor. Hypoglycemia is the single biggest challenge that we face when treating diabetes.
Wonderful. And I think you've covered the precautions actually, because you said watch your physical, make sure you're eating on time, and watch your dosage.
And one line there would be that with newer medication, if you're not on insulin, and some of them, you don't get hypoglycemia at all. So in OPD management, our risks of hypoglycemia have gone down dramatically over the last 10 years because the newer drugs don't cause it.
Interesting. Very interesting.
So that's it.
Thank you, Doc. From Shivani, thank you, doctor. We have an 83-year-old with diabetes living in a multi-story complex. The household has 6 adults, so he and his wife are in a bubble within the household. However, the maid comes from outside. What are the risks of going to a vaccine center to get a second shot? Would you recommend taking the second shot, or is it too risky in the current environment?
It's not a one-line answer. You have to weigh your risks. There is a slight risk in vaccine centers. You have to choose one that is not so crowded. You have to choose one where, so it's a lot of personal thing. I can't give a one-line answer. Yes. So if it's an 83-year-old and especially vulnerable group of people, I would say wait another 10 days. I think we are beginning to see a little decline in the peak. And if you can safely wait for next week, 10 days, it's okay. But don't wait endlessly, because then they're also unprotected. They're partially protected. So you have to weigh that. I would say everyone should get their second shot. Try and get a slot or something which makes it easy for you with less people and less crowding. If you really cannot do that, wait a little bit, and maybe second half of May, if it still doesn't subside, you'll have to go and get it anyway.
Yeah, I think we have to weigh the risks basically, right? And do it. Okay, from Nitika, is it okay?
But everyone has to get the second shot. We shouldn't delay it indefinitely.
No, and also, Doc, if you delay it past a certain point, then
yes, the efficacy will also go down.
The efficacy goes down. So I think there is a range, and I don't think one.
So for Covaxin, it's about 4 weeks. You can extend it by a couple of weeks here and there. For Covishield, you can go up to 12 weeks.
Okay. Yeah. Okay. From Nitika, is it okay to take precautionary steroid in low doses in case of slight increase in inflammation after physician's advice?
That's a very dicey area, actually. In general, no.
Okay.
The indications for steroids in COVID are a drop in oxygen.
Yeah.
That is the primary indication. Or marked rise in inflammatory markers in the second week, which is suddenly going up and the doctor is concerned. Or sometimes breathlessness, which is not responding to inhaled steroids, and you're worried about that, and subsequently do an HRCT that shows extensive disease. These are the sort of indications. But if you go by the textbook indication in this, it's only drop in oxygen.
Okay. Okay. But I think that's fabulous. The CRP levels, the blood work, the RCT, and
they're showing a very sharp increase than you may want to.
Great. From Shivani, sometimes the use of steroids are prescribed in either the first week itself on day 2 and 3. In the form of either oral Medrol or inhaler. Do you feel that aggravates the virus if it's used too early? What do you feel? Or do you prefer the use of oral Medrol or inhaler? Which one do you feel is safer and more effective?
So there's no question that inhaled budesonide is much safer and can be used at any stage of COVID. Inhaled budesonide will only have local action. It's not going to seriously impact your immunity in any way.
Okay.
Otherwise, on day 2, 3, in rare cases, physicians may opt for steroids, but by and large, it should be after day 5.
Okay, so inhalers are good, but
inhalers are good. Budesonide has shown amazing results in preventing lung complications of COVID.
Fantastic. Do you believe in steaming during COVID, or do you feel it can aggravate the situation?
I'm kind of neutral. I mean, so long as you don't burn yourself, it's not going to aggravate, because sometimes people take very hot steam and they can actually burn their mucosa. That's not a great idea. Otherwise, I suppose it's okay if you want to use it.
Okay. Is it safe to drink electrol to feel a bit more energetic for non-diabetics during COVID?
If you feel good about it, it's okay. But why would you drink electrol? I will just eat properly.
Okay.
Electrol is just a
From
mix of electrolytes. You can take it, no problem.
Right. Okay. From Rajiv, he's asking, Dr. Ambrish, when are you going to resume your OPD consult at Max Panchil?
I only stopped it because of the lockdown. Because
Right.
I mean, patients also, were preferring to come via remote. Moment lockdown parameters are sort of changed, or even before that, I will have to start. I mean, right now, because actually, what happens is in this situation, Panchil is an elective OPD.
Right.
So that is a little lower on the list. I will first start at Saket because
Absolutely.
their sick patients are required to be seen. And it's only been 2 weeks that I've been off. I mean, maybe next week I'll start again. Yeah.
Wonderful, doc. So just as you mentioned for the HbA1c value 6 to 7, can you tell us some thyroid values? That's from Poonam.
So thyroid values, it's important. I'm glad you asked that we go berserk over TSHs of 5 and 6. The TSH value normal, let's say, is about 5. Some labs say 4.4, some say 5.1. So let's say 5 is a cutoff for TSH. Most people between 5 with values between 5 and 10 TSH don't require any treatment and cannot attribute their life's problems, including weight gain and starting from weight gain and going on to divorce, to a TSH of between 5 and 10. So I think most people between TSH of 5 to 10 don't require treatment. Some do, that your doctor will judge for you, except a clear indication is if you're planning pregnancy or if you're pregnant.
Yeah.
In that case, you want TSH below 2.5.
Okay.
Otherwise, supposing I did a test and I found a TSH of 6.5, I would do nothing.
Okay, it's fine then.
Yeah.
You're fine. Okay, from Ekta, which is a good protein powder for diabetics if required post-COVID?
There are several. I mean, you can. I'll ask my nutritionist to speak to you, but there are several that are good. I don't want to take brand names here. There are at least
Sure.
4 or 5 brand names which are good to be used there.
Okay, doc. From Zia, how does COVID affect those who have Hashimoto's disease?
No issues. Don't get COVID, but if you do, it's not going to be an adverse impact. Although we are at the moment analyzing like we did for diabetes and vitamin D, we are now writing up our thyroid data with COVID, but nothing striking. Nothing striking.
Okay. With the third wave coming around, which could be critical for juvenile diabetes, can you state any protocols for children and how to handle them?
By and large, juvenile diabetics should handle COVID well, unless they've had very long-standing diabetes with multiple organ involvement. A typical juvenile diabetic should be able to handle it well. The issue will arise if steroids are required, then it'll have to be managed. So I don't think that there's much that you can do in advance except control your diabetes well, if there is blood pressure, control that well. I don't think you should be unnecessarily anxious about it.
Okay. This is from Aarti. My husband is diabetic, 52 years old. He was on gluconorm SR1G at morning and evening. He got COVID, has been on steroids for persistent high fever. Steroids are being tapered now. Sugars had gone to 300 range. Doc had prescribed Galvus 50 mg morning and evening and gluconorm 1G. Sugars seem to have come down now to 250. Would insulin be needed? He's never taken it before. Husband is diabetic, and as mentioned, he was having the.
So that's a very individualized decision. If the sugars are coming down a little bit and the steroids are being tapered, you can probably get by not using insulin, maybe adjusting the oral medication. But if the steroids are going to be there for long and the numbers are all 200, 250, then you will require insulin.
Okay. Doc, from Aarti, another Aarti, this is saying that if you've had COVID after your first shot and the second shot is due, can you, as soon as you get your negative result, can you take it, or do you have to still wait a couple of weeks?
I would wait 4 weeks after the
negative result.
A negative result or offset of COVID whenever it happens. Sometimes we don't recommend results all the time.
Okay.
But if someone has gone, 2 weeks are over. So let's say 6 weeks from onset.
Okay, 6 weeks from. onset. Okay. So somebody's asking, Vanita, can you get more than 2 doses of the vaccine?
Future will tell us that.
Yeah,
Future will
I'm
tell
not
us that. We
sure.
don't know. We don't know. But one thing is clear. What by the patterns we are seeing is that it's not going to be lifelong immunity or anything. That's
Yeah,
obvious, and we will require shots at least once a year, if not more.
right. How does COVID affect arthritis and osteoporosis patients with severe joint pains and obesity?
It's not a direct impact as such of the virus, but of course, the whole thing that goes along with the immobilization that happens for some time, if the sugars go up, for example, use of steroids may make a person feel. I have one of my patients who felt fantastic when they got COVID because they were given steroids and the joint pains all disappeared because steroids do those kind of funny things. So, but long term, obviously, for osteoporosis, is not good. I just explained that.
Yeah, correct. I know.
So,
Yeah.
so short term impact, not so much, but long term, of course.
Long term, yeah. You mentioned about how it does impact muscles and bones, but
Yes.
the questions come, so we ask. From Ekta, please advise if one should take vitamin K2 for better absorption of vitamin D, since it's the most crucial role in her perspective of COVID.
Yeah. Okay. So I'll again put this in perspective, just to make this audience familiar. Basically, my lifetime's work is vitamin D. Okay. Diabetes,
Okay.
of course, is very important for us. But in
Yeah.
terms of academia, if you ask, they will identify me as a vitamin D person. So that's, I mean, separate from patient care. But what
Yeah.
is important is for us to understand that vitamin D is important for us, but only in some amounts. And overdosing one with all these things will not really help us. So people are pushing too much vitamin D. People are pushing too much vitamin D, overdosing, getting high levels of
Yeah.
vitamin D. That doesn't matter. So what we require is 1,000 to 2,000 units a day, typically 2,000 units a day. So if you calculate that little thing you take is 60,000 units. And you may take it once a week for a few weeks, but people keep on taking it in the hope that, we'll get some amazing results, but it doesn't work. So if your hemoglobin is supposed to be 15 or 16, and if
Yeah.
you make it 20, it's not going to help you, right? So you have to understand same way with vitamin D. So you need small doses. You need it for long-term immunity. The levels of vitamin D that you should try to achieve are always should be above 20 nanograms, or in large lab it is 50 nanomoles,
Right.
right? And if you
Okay.
want to be really fussy, then 30. But it's not that people between 20 and 30 nanograms in Naveen's lab or others,
Yeah.
you will find that they're not deficient. They're okay.
Okay. Great. Doc, I think we'll just take another, I know you've also got to go, so we'll just take very quickly 2 or 3 quick questions. I'm not sure if this person heard your answer, but impact of COVID on a person with hypoglycemia, please.
No, hypoglycemia is not a disease. It's a very rare disease.
Yeah.
Hypoglycemia is usually happening in people who have diabetes. If that happens, that has to be managed accordingly. It's no separate
That's it.
impact. Yeah.
Yeah. Okay. And we've touched upon it earlier. From Sonali, people who have missed the boat for second Covaxin shot, that is, they couldn't get it done, beyond the 7 to 8 week mark, should they get a repeat of the first dose and then take a second dose?
I think no one can answer that. No one knows the correct answer. But yes, you could measure your antibodies. That will be a crude indicator of where you are. If you have reasonable antibodies, then you can take the second shot. If you have zero antibodies, maybe you should take 2 more. But at the moment, there's no such protocol. At the moment, the protocol is just 2 shots. Even if you are late, take your second shot and sit tight.
Great. Doc, from Monica, what is a safe period to end isolation after testing positive?
It's actually, if you go by the CDC guidelines, it's 10 days, like 10 days from the onset of symptoms, 3 days after you've had no symptoms at all.
Yeah.
So being extra cautious and sometimes being confused about when the patient started symptoms, etc., I make it 14 days.
Okay.
But I think you're pretty safe after that.
So rule of thumb is, isolate 14 days and then you're not contagious, at least to others.
Yes, you're not. Probably at 10 days you stop being contagious, but 14 days.
But to be on the safe side, I think right now we can all just, do that. Okay, Doc, I think, do you want to leave everybody, the audience, with some thoughts or some care protocol or anything for the audience for diabetes?
So, no, in fact, I won't leave anything with you for diabetes, but I will say something very basic. Whether you're a diabetic or not, the major thing is that while there are multiple reasons for this huge surge that we are seeing, including maybe some mutations and all that variants, one major reason has also been our own laxity in dealing with it. We are not comfortable with masking. We can't avoid social interactions. People have been, their weddings, this, that, and people took so much risk. And some didn't have anything, but some got into real trouble. So I think that we will have to learn to live with masks for this year and maybe next year. And masking is serious and to be kept there all the time, except when you're with everyone who's vaccinated.
Yeah.
Otherwise, you would need a mask. And even if you've been vaccinated, don't give up your mask. So, and this touch thing, this fomite transmission is not so common.
Yeah.
Outdoor transmissions are not common. It is within our rooms, within our offices. Maximum outbreaks have occurred in offices, in parties, in celebrations. If you're in the office, someone joins you for a cup of coffee, that's a disaster.
That's a disaster.
If you're with friends and if you just take off your mask to have a birthday cake, disaster. So masking in indoor environments is mandatory.
Absolutely.
Don't forget that. As we learn more about airborne and all that, in 6:30 I have to talk about that.
And no, exactly. And Doc, that's why we're finding families going down together, right?
Yes.
Absolutely. So, Doc, thank you so much, Dr. Mithal. It has been such an amazing session. Really appreciate you coming on for Need of the Hour. And a big thanks to our audience who tunes in and everybody who joined us today. Thank you so much. Tomorrow we have with us Mr. Amit Pandey. He is a senior consultant and physiotherapist, and he's actually going to be talking about how to rebuild your lung health. What are the exercises that are required right now to actually build your lungs up. So please do join us tomorrow, 5:30 p.m. Thank you so much.
I'd like to thank everybody. Thank you for inviting me. I really enjoyed this, and the questions reflect the level of the audience, and I've thoroughly enjoyed this. Thank you very much.
Thank you so much. Thank you so much. We are indeed very grateful to you, Doc.